Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, colleagues. It's my pleasure and honor to welcome you tonight on behalf of the Saudi Society of Blood Disorders and Novo Nordisk for this activity today, which is on the update on hemophilia management. My name is Hazza Al-Tarani. I'm a consultant hematologist at King Faisal Specialist Hospital and Research Center, and it's my honor to chair this meeting today on the 20th of October 2021. So the meeting today will have two main lectures, and then we'll have a question and answer session. The first lecture will be presented by Professor Muhammad Gari, who will speak on the individualization of treatment of patients with hemophilia. And then Prof. Herman Eckler will speak on the topic of a simple way to achieve low annualized bleeding rate. Then we will have a discussion session at the end of the meeting. So it is my honor and pleasure to introduce our first speaker tonight, who is Professor Muhammad Gari. He is a professor of hematology at King Abdulaziz University in Jeddah. He's the president of the Pan-Arab Hematology Association, as well as the founding president of the Saudi Scientific Hematology Society. Prof. Gari is the deputy director of the Center of Excellence for Osteoporosis Research and the chairman of the hematology department and the director of clinical laboratory at King Abdulaziz University. He has more than 80 publications and participated in many clinical trials. So it's a great honor and pleasure for me to introduce Prof. Gari to kindly present on the topic of the individualization of treatment in patients with hemophilia. So Prof. Gari, please.
Yes, indeed. I'm waiting for the slides to be shared.
Thank you.
If you can kindly allow me, whoever is managing. All right, here we are. Good evening, ladies and gentlemen. It's a great pleasure and honor to be joined by two great eminent experts in the field of hemophilia. It's an honor for me, and I'm pleased to speak on one of the favorite topics I would like to speak on, hemophilia. I would like to thank the organizers of this meeting, and also thanks to the Saudi Society of Blood Disorder, who's continuously giving us opportunity to listen to very interesting topics. And this time, it's time to hear a few words about the tailored dose in hemophilia prophylaxis. I think my presentation, if this was like a virtual dinner, this is the appetizer. The main dish is going to be by Professor Eckler, who's a very well-known expert in this field. So tailored hemophilia, first I have no conflict of interest to declare. And I am sure that all of us are aware that hemophilia treatment requires attention to the scenarios of the patient life, the presence of inhibitor, the patient needs, and the pharmacokinetics and the patient history and lifestyle. So among one of the factors that we should consider highly, the pharmacokinetics of the drug. And here we're going to see how the pharmacokinetics play a great role in achieving good prophylactic regimen. First, the prophylactic regimen idea was started in 1960 based on a very simple idea. If you have a patient with severe hemophilia and he bleeds so often, then the chances of him bleeding less is to higher the factor VIII level from below 1% to above 1%. And then you are transferring a patient from the category of the severe to the mild to the moderate type of hemophilia, and hence he will improve. This will improve the quality of life. But until definitely there is no consensus on the optimal treatment regimen so far. But as this prophylaxis regimen started to appear, where you would like to increase the factor level to change the life of those patients, challenges started at the same time. One of the challenges commonly is when you give a factor VIII 3 times weekly, you may reach a point where the trough level is becoming 1% or less. And in that case, your patient is exposed to arthrosis and traumas and the bleeding events. So this kind of scenario commonly occurs if you give 2 or 3 times weekly. There will be a trough level of very low factor VIII.
Do you mind, Dr. Muhammad, to make the slides as a slideshow, or whoever is?
Sure. I forgot to do that. Sorry. Why measure factor levels? Sorry, to go back. There is a wide interpatient variation in the trough level, and there is success of prophylaxis determined by maintaining an adequate factor level of 1% or more, and there is a debate on the appropriate trough level needed to prevent bleeding and the interpatient variability. So the full protection against bleeding is achieved at factor level trough of 10 to 15 international units per deciliter, which is definitely very costly and not doable at all, but it gives very high protection. Among the challenges associated with pharmacokinetic measurement of factor VIII is the discrepancy in the factor VIII assay. We have the one-stage assay, which is functional measurement of factor VIII, and we have the chromogenic assay, which is antigenic measurement of the factor level, and then we have plasma-derived and recombinant factor. Those definitely will behave completely different in the patient body. And we have the beta domain deleted factor VIII, in which there is 20 to 50 discrepancy between the clot and the chromogenic assays. This is particularly observed with Morocco. Among the other challenges in measuring the pharmacokinetic is the individual patient pharmacokinetics. Different methods of plasma volume estimation may yield different pharmacokinetics, and also what time you took the sample, the timing can make a difference and affect the value of the pharmacokinetics levels. Certainly, why we measure factor VIII, we measure factor VIII to determine the diagnosis, and in case of severe, we have less than 1%. In case of moderate hemophilia, we see 1 to 5%. In case of mild hemophilia, we see factor level between 5 up to 40%. We also measure factor VIII to ensure correct dosing. World Federation of Hemophilia recommend the desired target level of factor VIII for different situations. For example, if patient has a joint bleed, you want 40 to 60 international units per deciliter. And if he has CNS bleed or major life-threatening bleeding, you require 80 to 100 international units per deciliter. We need factor VIII estimation to monitor the inhibitors and to monitor the treatment and prophylaxis. And I think this is the most important part for today's presentation. Factor VIII pharmacokinetic parameters are determined using assay, which measures factor VIII activity or antigenic presence. The one-stage clotting assay is the functional assay, which is widely used in the clinic. It's easily done. It can monitor the treatment progress and assays more susceptible variation in the functional assay. The chromogenic, however, is limited use in the clinic, but it yields a better and less variability than the clotting assay, and this is requested by EU for potency labeling of a product and for licensing. So let's throw some light on pharmacokinetics. If we understand what pharmacokinetics is, we'll be able to see why do we need to tailor the doses for the patients. First, we'd like to define pharmacokinetics and pharmacodynamics. We'd like to describe the parameters used, and we want to see the reason to measure factor VIII level and its pharmacokinetics. Pharmacokinetics is defined as the study of the behavior of the drug, its absorption, distribution, metabolism, and excretion. And this is sometimes defined as what the body does to the drug. While pharmacodynamics is a later stage, it is the relationship between the drug concentration at the site of action and the resulting effects. This includes the time course and intensity of the therapeutic and adverse effect. And this is sometimes defined as what the drug does to the body. So the pharmacokinetic is defined as what the body does to the drug, while the dynamics is what the drug does to the body and how we react to the drug and how do we see the effect. If you look at this in a chronological order, you will see if you prescribe any dose of a drug, the pharmacokinetics will be in this part when the drug reaches the site of action. There are factors governing this stage: compliance, dosing, tissue and body fluid volume, elimination, and metabolism. And then when the drug starts to have an effect, it will have an impact on the body. Then factors like genetic factor, other coagulation factor, presence or absence of inhibitors, and this is the stage where pharmacodynamics is involved. So the first stage is the pharmacodynamics of what the body does to the drug, and then the pharmacodynamics is the effect of the drug or what the drug does to the body. There are certain parameters commonly used, and we have to throw some light on this. We have the drug plasma concentration over time, and commonly we use the term AUC, area under care. This measures the ability of the drug to remain in the body without being metabolized. In other words, it is the whole time spent in the body and the decline of the concentration until the concentration will reach the lowest level, which is the trough level. So the whole story is area under the curve, and it will show how much time took for the reaching the Cmax or the maximum concentration, and how much time took by the drug to decline or disappear from the body. Another important term is the T-half, or the half-life, which is showing us the clearance or the rate at which the body removes the drug from the from circulation, and the T-half is the time taking to remove half of the dose from the circulation. This is the T-half. So let's apply this to factor 8 and see how does this work. I have 3 examples of 3 drugs. One of them is this one. This is the drug which is given in infusion 1 and infusion 2 to different subjects in front of you here. Those are different subjects, 1, 2, 3, 4, 5, 10 patients given the drug. This particular drug has similar pharmacokinetics in all the subjects. And even among the same individual, the pharmacokinetics is similar over time. That means if you give dose infusion 1 and infusion 2, it will behave similarly. The concentration will be the same, regardless of it is given to one individual or given to several individuals. So we have a very constant and nice and linear relationship between the dose and the concentration of the drug. So this is an ideal drug that would work without any difficulty. You can decide one dose that fits all. One size fits all. One dose is good for everyone because we know the behavior of the drug and is going to work nicely in the same concentration in different times among different patients or within the same individual. This is what we call linear relationship. An example of such a drug is paracetamol. You give 1 gram to everyone and you expect a very good effect. Now, on the other direction, we have this drug. This is another drug that works completely opposite to the first one. This is the drug if given to different individual is going to behave completely bizarre from one patient to another. And even within the same individual, as you can see here, the concentration can be either here or here. It can be either or here or here. It can be in different times, giving different concentration. So the patient would have different pharmacokinetics, and individual himself will have difference in the pharmacokinetics in different times. So this is a very non-linear drug. An example of such drug is warfarin, where you give a dose to the patient, you can change it from time to time because it's non-linear drug, and even the same dose will not fit everyone. So this is completely non-linear drug. Warfarin is a good example like this. Now, what's the relationship between paracetamol and warfarin? Well, one of them is linear, the other one is non-linear. But what the factor concentrate does here? The clotting factors is actually lies in the middle. It is not completely non-linear. It is not completely linear. It is different among individuals from patient to patient. You will have variation in the pharmacokinetics, but you have constant pharmacokinetics similar over time if you give it to one individual. You can see here, this is subject number 1. He has the same 2 infusions. He has the same effect. another individual who has this good effect, and a third individual will have constant effect at different times. So it is linear from in one patient, but if you give it to different patients, you need to individualize the dose. And that's where the idea of individualizing or tailoring the dose came from, because clotting factor behaves in this partially bizarre way. Even if you measure different types of products, all of them are factor 8, regardless of their origin. They have different T half-life, they're different pharmacokinetics too. Why we measure pharmacokinetics parameters? Variation in the pharmacokinetic parameter leads to potentially large inter-individual differences in factor 8 coverage. And the European Medicine Agency requires pharmacokinetic parameters as part of giving approval for a drug. If you can see here, you have 3 types of factor 8, and their concentration is good and linear in the first stage of when you infuse the drug, but later when this drug declines, you will see that one of them has longer half-life, one is average half-life, and the third one has shorter half-life. So there is a huge difference in the decline phase. And one of the important things that the international standard ensures comparability of the assay results, WHO established reference reagents for the clinical use, plasma sample, and for potency labeling. So this plasma sample is used as a comparative plasma in order for you to make your potency of your factor 8 compared to this international standard plasma or factor, then whatever production of factor 8 will be given a standardized value as compared to the international standard plasma. One international unit of factor 8 activity equals the amount of factor 8 in 1 ml of normal human plasma, and one international unit is the activity measured against this international standard, and that will help you standardizing your management because we are using different types of factor 8. But if we compare them to the international standard and we multiply by the factor, then it will be as if we are using the international standard plasma itself. And this leads to factor 8 level increase of 2%. Each international unit will give rise to 2% rise in the factor. Why does this matter? Because knowing patient pharmacokinetics, we can use it to derive dose and frequency that will achieve good pharmacokinetic target. And this is always above 2%. We don't need standard plasma to compare the bioavailability, knowing that this has been done at the manufacture stage and the linearity existed in the previous study. So we don't have to do any procedure to compare or to standardize. It is already standardized. In essence, we need a drug which behaves in the body similar to the manufacturer claim. This is what we want to achieve. We want something or a factor 8 that will behave in a way similar to what is written on the box. Once I know patient pharmacokinetics, I can simulate what the ideal dose and frequency, and this will enable me to achieve good pharmacokinetics for my patient. I will also not know that this dosing regimen will be valid for quite long time and will be consistently coming in the same way as it should be. For example, if I'm using, for example, a dose of 2000 international unit Q48 hours, this was not good. Why? Because at the trough level, the factor 8 concentration will drop to below 2%. So here, at this stage, I'm exposing my patients to bleeding. So I have to optimize the dose and measure pharmacokinetics again. For example, in this case, we optimize the dose to 2,500 international unit every 48 hours, and we achieved a trough level above 2%. Here, patient is very well protected from bleeding. How do we determine patient pharmacokinetics? This was done by the ISTH earlier, and they have carried out this design study in which there is 12 to 15 patients with a crossover design when 11 to 15 samples of the blood samples were taken in a period of 32 to 48 hours after infusing 25 to 50 international units per kg, and then followed by washout period. This enabled ISTH to put in their guideline the population pharmacokinetics of the particular factor 8, and they have drawn this graph to help physicians. This was not the end of the story. This was followed by the development of personalized tool, which was the WAS Hemo. This is an application in the mobile in which the study by the ISTH, the POP-PK, the Population Pharmacokinetic Study, is supplemented by what we call sparse sampling, where we focus on particular individual with hemophilia A. We measure 2 to 3 samples for factor VIII for one patient over 48 hours. And adding this 2 to 3 sample results to the population pharmacokinetics in the graph, then we can achieve individual pharmacokinetics, and we can draw a graph that is peculiar to this patient. We use a population pharmacokinetic model and individual samples to derive an individual estimation or a personal graph that will help the patient. And this app is available for downloading for all your patients. It's called My Maps. I have it in my mobile, very interesting app. And this is a monitor, it will monitor the factor level. Every minute you can open it and see what the factor level is in your patient, or he can see for himself what is factor level. He will know if this factor level drops below the graph. He will receive reminder when it is time for the infusion, and he will receive notification when the factor level drops to below the zone of 2%. So this is a tool or an application that is now downloaded in 412 centers of hemophilia all over the world, mainly in North America and in United Kingdom, and to a lesser extent in other parts of Europe and the Middle East and China, as well as Australia and South America. Some other countries do not have it. In this tool, there are registered 4,248, and the total pharmacokinetic studies done were 8,000 plus. This included children from 6 to 11 and 0 to 5. This is the look of the app. It will show the current level of the factor VIII. In any moment, the patient opens to see, and he can see how much he have how much time he has until he have the infusion. He can link it to his smartwatch, and he can see the results all the time. So it keeps the patient in touch with his factor VIII simply by using the population pharmacokinetic added to the personal pharmacokinetic from the 3 samples taken from the patient. Benefit of the pharmacokinetic tailored dosing in hemophilia, it can reduce the cost of treatment by simply reducing the drug cost and bleeding events. This is compared to standard prophylaxis treatment without the pharmacokinetics. And reduction in the bleeds per year or annual bleeding rate, and increase in the quality of life, tendency towards improvement of annual bleeding rate in the adherent group versus the non-adherent group. Longer time spent above either 1 or 5% were associated with a decrease in the annual bleeding rate. I would like to leave you now with just reminding you that it is very important to tailor the dose, because tailoring the dose will give you better confidence and improve patient quality of life. I don't think I can emphasize this more, because if you tailor your suits, you should tailor your patient dose. Thank you very much.
Thank you very much, Prof. Gary, for this very clear and very interesting presentation. We appreciate your sticking to time and a very informative lecture. It is my honor and pleasure to now introduce our next speaker. We'll have the questions and answers at the end of the presentation, Prof. Gary. And we also, I think there are many questions in the chat box about the CME hours and also about the attendance certificate. The attendance certificate will be presented, will be given to those who will attend 50% of the lecture. Now, it is my honor and pleasure to introduce our next speaker, Professor Herman Echter, who is a professor of transfusion medicine and clinical hemostatsiology. He's also the chairman of transfusion medicine and clinical hemostatsiology at the Saarland University. Professor Herman had his medical degree at the University of Würzburg in Germany, and then he performed clinical training in pediatrics and anesthesiology at the same university in Frankfurt. Then he did clinical and scientific training in transfusion medicine at the University Hospital of Marburg in Mannheim. And then he finalized his postdoctoral qualification at the Heidelberg University in 2005. In 2006, he had the position of full professor in transfusion medicine and clinical hemostatsiology at the Saarland University. And since then, he has been chairing that institute at the Saarland University. He's heading Certified Hemophilia Comprehensive Care Center, and his primary scientific interest is in the patients with congenital and acquired coagulation disorders. He and his team is involved in several clinical trials, ranging from phase 2 to phase 4 clinical trials, and a basic research of blood coagulation and treatment of blood components. So it's a great honor and pleasure for us to have you, Prof. Erfer, to present today on the topic of how to get a simple way, or how to do a simple way to achieve very low annualized bleeding rates in patients with hemophilia. Professor Erfer, please.
Yes, thank you very much, Dr. Asarani, for this very kind introduction. And I would like to thank the organizers to invite me for this great meeting. And I would like to thank Professor Kari for his perfect presentation that gives me the chance to know that you now knew all these basics necessary to understand what I would like to present you. And yeah, my lecture is called A Simple Way to Reach a Low ABR, a low annual bleeding rate. What's very interesting is looking to the clinical side of the patient's treatment. We have since years in Germany and other countries the procedure of prophylaxis. That means that a patient gets, as Professor Kari explained, several injections of factor concentrates per week, and we want to reach a trough level that has defined over years of more than 1 or 2%. So we want to let the patient in a situation that he is from severe to moderate hemophilia, and that the bleeding events go down. And this is a good way to lower ABRs, not to zero, but some patients reach nearly zero with such a procedure. So our standard factor VIII products that are not extended half-life, but standard half-life products, we used it every 2 to 4 days with the aim to achieve a plasma factor activity of above 1%. And when you do this, and do this over years or decades, the patient will not have many bleeds, but looking to his joints, you will see over years, here's our data from the Bonn Haemophilia Center, the biggest center in Germany, with more than 400 patients with severe hemophilia A and B. You will see over the decades that the joint score will go up. That means, for example, this Gilbert score, that's an X-ray based score, you will leave the range of normal after 1 decade. And although the patient gets his prophylactic treatment with troughs of 1 to 2%, he will generate arthropathy. And that's not good, because patients have now a normal lifespan, a nearly normal lifespan with hemophilia, and we would like to protect the joints from arthropathy. So joint damage can occur in asymptomatic patients despite prophylaxis. That's a crucial thing we have to face now. And one way to increase the trough from 1 to 2 to probably 3 to 5%, and these are now the guidelines from the World Federation Haemophilia and also national guidelines here in Germany, we want to reach 3 to 5% TRAF to preserve the joint health. That means that you need a technology to prolong the half-life of your factor VIII molecule. And there are different technologies you can use. This is all done by protein modification. It's not possible with plasma-derived factor concentrates. It's only possible with recombinant factor VIII molecules. You can fuse your factor VIII protein with other proteins or molecules like albumin, that's used for factor IX, or FC fragments, or von Willebrand factor fragments. The binding to von Willebrand factor changes, or that the recirculation of factor VIII is possible. Then with these technologies, you can reach longer half-life. But you can also do attachment of covalent attachment of special molecules like polyethylene glycol, or desalinization, or amino acid strains. So polyethylene glycol, PEG, is very well known in human medicine. It's used since the 70s. PEGylation means that you have a covalent attachment of PEG chains to a therapeutic molecule, and this improves the PK, the pharmacokinetic property of different therapeutic molecules. PEG is inert and non-toxic. It's soluble in water. It's cleared out from the body. And it's approved by FDA and European Medicine Agency for human use. And it's used not only in factor concentrates, but in other proteins or drugs for many years. So look here, it's used first time in the 90s, and from 2000 on, PEGylation is used for several therapeutic principles, and from 2017 also in factor VIII and factor IX products. What makes PEGylation? PEGylation works in three main mechanisms to increase the half-life of a factor VIII molecule. First, it increases the size of the molecule, and therefore the kidney filtration goes down. Secondly, it also increases the solubility due to the PEGylation and the hydrophilicity, and that means that it's better soluble in the plasma. And third, due to steric reasons, because this is an addition of the molecule, it decreases the accessibility for proteolytic enzymes and antibodies to clear factor VIII. And when you add a PEGylated molecule to a body, you get a concept of steady state on the long-term use of such a drug. First of all, you get an accumulation phase where PEG is accumulated in the body, but that does not go on forever because you have excretion reactions, and therefore you have a steady state, although you further use the drug, and after cessation of the treatment, the clearance goes on, and PEG will disappear from your body. So Torotococc alpha pegol, or HGP, is such a factor VIII molecule with a PEGylation. Novo-8, the recombinant factor VIII product for Novo Nordisk, is known since 2014. And on the B domain of this molecule, there's an HGP is linked to this glucopegylation site. You have a 40 kilodalton PEG molecule per molecule of factor VIII. And when thrombin activates an HGP, the B domain gets deleted, gets cleaved from the factor VIII molecule, and with the B domain also the PEG is cleaved from a molecule, and the active molecule is activated factor 8, and it's the same like Novo 8. So this NHGP molecule was tested in a huge clinical trial program that's called Pathfinder. And I will lead you through this Pathfinder program with a few slides. It was one of the biggest programs performed in hemophilia A, more than 270 treated patients. It was a 6-year trial phase, more than 6 years, a clinical more than 1,000 patient years of exposure in more than 80,000 exposure days. And this is the a trial program at a glance. It started in 2010 with Pathfinder 1, the phase 1-2 study with pharmacokinetic and safety data. Then in 2012, the pivotal phase 3 study started, called Pathfinder 2, safety and efficacy for patients higher of 12 years of age. This Pathfinder 2 trial was then, after the main phase, extended in 2 parts, extension part 1 and 2. And in the extension part 2, there was a Pathfinder 7 trial, another PK trial that was necessary because Novo Nordisk changed the production plant from Denmark to the United States. And this new production plant had been tested by a new pharmacokinetic testing, whether the new product is completely the same compared to the product produced in Denmark. So 2 PK trials. And then when the patient needs a surgery in the Pathfinder 2 trial, he can move to the Pathfinder 3 trial, the operation trial. There was also an extension phase. And then we had the phase 3 trial for the children below 12 years of age, also safety and efficacy with an extension part. And the Pathfinder 8 trial is the phase 3B trial for PTPs. And it's running in some countries. In Germany, it's finalized last year because of the marketing of the product. And also ongoing is the PUB trial, Pathfinder 6. So let's have a look to the Pathfinder 1, phase 1-2 trial for pharmacokinetics and safety. So that's the trial design for the PK analysis. 27 patients were screened, and they had a visit 1. They get an injection of the previous factor 8 product with a washout before. Then it was analyzed in phase 2. Then was the same dose applicated with NHGP after washout, and it was analyzed. And then there was a follow-up visit with antibody analysis. And 3 dosing regimes were tested, 25, 50, and 75 units per kilo. And this is the graph of the pharmacokinetics in light blue. It's a standard factor 8 product that was used by the patients before entering the trial, and the dark blue is the NHGP 50 units per kilo PK. And you clearly see that the area under the curve is bigger as the standard product, and the half-life is extended. So the half-life was in a mean 19 hours compared to 12 hours for the standard product. When you use 50 units per kilo and you analyze the time until you get a trough of 1%, for an HGP, it was 6.4 days, and for factor 8 standard, it was 3.6 days. So this was a standard half-life product. You see, although the half-life is seems only slightly to be enhanced, you have a very big difference in the time to reach a trough of 1%. And the area under the curve is 1/3 higher with NHGP compared to the standard product. And when you add also the PK data from Pathfinder 7 from the later done PK study, you have even a higher half-life of around 20 hours of an HGP in the area under the curve that is slightly increased. So Pathfinder 2, the phase 3 pivotal trial for previously treated patients over 12 years of age. This is the trial scheme. You have PTPs with severe hemophilia A. 186 patients were screened, and the majority went to the prophylactic arm, NHGP 50 units per kilo every 4 days. Only a few patients went to the demand trial arm. Then these patients were, after the main phase, randomized to go to a 75 units per kilo once weekly arm, or staying on the 50 units per kilo every 4 days arm. This was only possible for patients with low ABR to switch to the once weekly arm, and half of the patients that went to this arm went back to the 50 units per kilo arm because of a bleeding event during the trial. So it's a selection of patients for this 75 once unit. Okay, NHGP was well tolerated in adults and adolescent patients. The one patient, one PTP patient developed an inhibitor after 33 exposure days. Was a patient with an intron 22 inversion and used no NTI, used no ITI, returned to previous factor VIII product, and the inhibitor status was then negative. And it was analyzed that the estimated factor VIII inhibitor rate of 0.13% per patient year is enough to explain why one patient of more than 100 changed to an inhibitor. So that was not a signal, it was located to the trial product. So no safety concerns, no thromboembolic events or anaphylactic reactions, no adverse events that lead to a withdrawal of patients. And for the PEG use, there were no safety concerns. In here, the main and extension phase data of Pathfinder 2. First, the main phase. So let us have a look to the prophylactic patients, 40 units per kilo every 4 days, 175 patients, and 40% of these patients had 0 bleeds during the complete main phase. The mean ABR was 1.18 with this range, and the spontaneous bleeds were 0. So nearly no spontaneous bleeds with this treatment regime. And when you add the extension phase data, we have 176 patients, 29 without any bleeds, 0.84 median ABR. That's really good for a clinical trial. And for spontaneous bleeds, we were at 0.35. So very impressive data. Looking to the extension part of the 75 once daily group, less patients. Patients with 0 bleeds were lower compared to the 40 units kilo trial arm, 40 units trial arm. And the mean ABR was higher, and the mean ABR for spontaneous bleeds was even higher. So in Germany, in our center, we do not see that this once weekly dosing is the treatment of choice using NHGP. All our patients are using this regime every 4 days, or even twice daily, 50 units per kilo. And you have one patient on this regime. This is the patient that also was in the exploratory trial. So what happens when there's a bleed? over 90% of all bleeding events were treated with 1 or maximal 2 injections with NHGP. And so bleeding is no problem when you use NHGP for treatment. You have control on nearly all bleeds. This is very interesting because the every 4-day 50 units per kilo arm showed a mean trough level of factor VIII of 3.1%, and that's quite high. And this is the graph of the that shows you that the time with factor VIII activity over 5% is 90% of your treatment time when you use this treatment regime. And when you extend it to twice weekly, 50 units per kilo, because for some patients every 4 days is a bit hard to organize, twice weekly, it's a bit higher dosing, then you have 95% of your treatment time trough levels of more than 5%. And it's really impressive. And you get troughs of 3 to 4%. So what's about surgeries in the Pathfinder 3 trial? Here's the regime. The patient needed an elective surgery, went from Pathfinder 2 to Pathfinder 3, was a screening, a day of surgery. Pre-surgery dose of 50 units per kilo was injected with a target level of 80 to 100% factor VIII activity. And in the post-surgery phase, there were the target levels that should be reached, 30 to 50 to 80%, depending on the post-surgery day. And here's the end of the trial with the analysis of the data. And there was a very high success, hemostatic success rate of 95.5%. That means that half of the patients had an excellent hemostatic activity, that means better than expected, and 45% had an hemostatic activity as expected. That means with NHGP, it's very good possible to make bleeding control also in orthopedic surgeries like hip and knee surgeries. So the Pathfinder 5 trial with patients below 12 years, with the children, they got an injection of 60 units per kilo twice weekly, with a main phase and extension part, and the same key objectives: immunogenicity, safety, efficacy, PK model-based, and as key endpoints, incidence of inhibitors and adverse events, and so on. 86 patients were entered the trial less than 12 years. And here are the analyzed bleeding rate data, split in 2 groups. The one group is the younger children, 0 to 5 years, and the older children, 6 to 11 years. The same number of patients, and the number of patients with bleeds, 76.5%, and 1/4 had no bleeds during the main phase. And the number of bleeds, 108. In the older children, you had a lesser frequency of patients without bleeds of nearly 15%. The observed ABR was around 1, and that's also good for this very active and hard to treat a group of patients. And this is interesting because when you have patients with target joints and you start treatment with an extended half-life product such as NHGP, 12 patients participated in this main extension phase and had 16 baseline target joints. And you see here, over the course of the study, the target joint number went down. 15 target joints were resolved within 2 years, and all baseline target joints were resolved within 25 months. And it was also observed over the longer period of time in the adult study where the patients over time get lesser ABRs due to better situation of their joints, and the same is here in the children's group. So these are the data, and I would like to add our patients, patient A and patient B, that were part of the Pathfinder trials. They went in 2012 in the phase 3 and were treated over 6 years in this trial. So the patient A was is a 30-year-old man with a normal body weight, normal BMI of 22. He's very active. He's a sports student, makes endurance sports, and he has a diagnosis of severe hemophilia A with intron 22 inversion. His medical history in previous treatment, he got a recombinant factor 8 prophylaxis 3 times weekly with a non-half-life extended product, and he had a low grade of arthropathy with slightly impaired movement of the right elbow. So he entered the study, but before, this was a standard half-life treatment with recombinant factor 8 in the last 12 months, 3 times per week, 27 units per kilo, and he had a total ABR of 1 spontaneous bleed and 1 joint bleed, 1 spontaneous joint bleed, and that's a well-treated patient for a standard half-life product. And the trough level we saw was 1% with a peak of around 50%. Then he entered the Pathfinder 2 trial with a 50 units per kilo every 4-day regime, and was there for nearly 7 years. And in these 7 years, he had only 2 traumatic bleeds, no spontaneous bleeds, no joint bleed, and a total ABR of 0.3. And look here, his troughs in the trial were between 2 to 8%, with peak of around 100%. So he was very content with this procedure. And he stayed there for more than 6 years, and he had 1 dental surgery. This was performed also with NHGP without any problems. Patient was very satisfied with the NHGP prophy, and the dosing was perceived as a huge improvement of therapy. Now the patient is off Esperoct because he is now in a gene therapy trial and was one of the first patients in our center that get gene therapy for hemophilia A. The second patient, as a 32-year-old patient with a high body weight but normal BMI, is not very active, makes no regular sports activities, but he is a family father with small children. Therefore, he is very active with his children, and he has a severe hemophilia A with a stop mutation. In his previous treatment were a plasma-derived standard half-life product 3 times weekly with 32 units per kilo. Medical history, he was migrated from Eastern Europe to Germany at the age of 8, and then started his secondary prophylaxis. He had really advanced arthropathy in both ankle joints and elbows, and he already had a synovectomy of the left ankle in 2009. He needed to use an anti-inflammatory pain medication on demand, and had a post-chronic HCV infection that was successfully treated. This was his treatment before entering the trial, standard half-life, plasma-derived. He had a low ABR, but low troughs of 1 to 2%, but higher peaks of around 90%. Then he went to the 50 units per kilo trial arm, went there for 16 months for the main trial part, with troughs of 5 to 10% with high peaks. But this was very, I was very happy to see this higher troughs in this patient because of his arthropathy. Then he decided to enter the 75 units per kilo once weekly arm for 51 months, and he left there because he had no bleed. total ABR of 0, one traumatic hematoma that was resolved without treatment. But look here to his trough level. It went down from 5 to 10 to 1 to 6% with high peak levels. And this was the end of the trial. When he came out, he stayed on Esperoct and still stays on Esperoct once weekly. He wanted to stay on this once weekly dosing. He was without bleed and accepted his lower trough levels. He was very satisfied with an HCP prophy once weekly. 7-day dosing interval was easy to integrate in his family life with small children. And he was considered a great improvement to the previous treatment. So to sum up, an HCP is a glycopegylated extended half-life factor VIII molecule with a 1.6-fold longer terminal half-life compared to standard factor VIII products. The measured mean factor VIII trough levels in the trial were 3% with a 50 units per kilo every 4-day dosing. 90% of the time you have more than 5% factor VIII activity. That's very positive. It's a very effective prophylaxis with a mean ABR of 0.84 with this treatment regime. Nearly all bleeds can be effectively treated with 1 or 2 injections with a very high success rate, also in major surgeries with a good bleed control. The Pathfinder patients at our Homburg center were very satisfied with an HCP prophy over a period of more than 6 years. So thank you very much for your attention, and I'm open for questions.
Thank you so much, Prof. Eckhart, for this very nice and clear presentation on the Pathfinder programs. I think we have time for questions. I don't see any questions in the chat boxes, but maybe I can ask a question to Professor on the best way to measure Esperoct. Is it chromogenic or one-stage assay?
We use the one-stage assay if we know that the patient is well treated. In the beginning, we are using the chromogenic assay to really see where the troughs are. So, but monitoring the patient over time, when we see, we compare then the troughs of the chromogenic and the one-stage assay, and we use it for long-term monitoring. We're using the one-stage assay, but not at the beginning. We want to see the chromogenic results.
So in your day-to-day practice outside these trials, if someone is undergoing major surgery, you monitor with one stage? Is that what you do?
We are monitoring with the one stage because when, for example, the patient needs factor VIII treatment at night, so we do not get chromogenic assay results at night. So we have to use the one-stage assay, but it's a bit of feeling and knowing the patient behavior, as Professor Query already told us. The intra-individual variation is low. The inter-patient variation is higher. But when you know the patient's PK, it's also in the treatment of surgery, it's easier to handle this patient.
Thank you very much, Prof. Prof. Gary, a question on adoption of the individualized pharmacokinetics in Saudi Arabia and at the Ministry of Health level. I know there is a lot of activity in the Ministry of Health in Saudi Arabia to optimize the care and choice of anti-hemophilic therapies. Are you aware of any ongoing, activities along the, especially in adopting the individualized pharmacokinetics?
Certainly. At this moment of time, I'm not aware that there is anybody in the level of the authorities who's adopting this. But I think it should start on the level of the individual physicians, like yourself, like our center in Jeddah. We can adopt the MyWAPs. I already had the MyWAPs, but I had difficulty in introducing the Esperoct at the moment in our center. But soon it's been approved by the committee, so soon it will be available. And I think many centers will follow. So once the Esperoct will be available, then it will be a very good idea to, along with this, we start to adopt the MyWAPs application or whatever, I mean, pharmacokinetics that's going to work well for the patients.
Thank you, Prof. Gary. And again, I'm looking at the chat box and questions and answers area. I don't see any. Maybe, Prof. Eckler, those 12 patients who had the target joints, were they selected because they were the only ones in the studies that had the target joints, or was there any specific selection criteria for these patients?
No, this was a subgroup of patients with target joints in the children's group. It was not selected, was only separately analyzed. So when there was a target joint, it was looked how it works during the study, and so the decline was observed, as I showed you. It was not a special group of patients specially treated. It was standard treatment of the 60 units per kilo twice weekly.
Thank you so much. And one more question on the pigulation in the studies of all these programs. Was there any systematically or predefined, in the study protocols, any predefined, look or mention of the pigulation and its short, long-term effect and the accumulation, and other than the classic hemophilia, outcome measures that was presented in your.
So in the trial, there was no measurement of the concentration of PEG in the body of the patients, but there was a measurement of anti-PEG antibodies, because anti-PEG antibodies could, in principle, reduce the activity of the molecule, but there was no observation of PEG antibodies that really affected the PK or PD activities. But it was not a measure of PEG in the, for example, tissue of the patient. It was not performed.
Are you aware of any studies looking at the degree of deposition of PEG in the cartilage? If it has a higher degree of deposition, could that explain the very impressive annualized bleeding rates in the 50 twice a week regimen, where the annualized bleeding rate was, you said, and was 0.8? You know aware of any of this?
Do you mean that the PEG could have an effect on the?
No. I mean, it may stick better to the cartilage. Does that? I'm just thinking. Does it stick better to the cartilage, the lining of the joints, and therefore prevent?
So the hypothesis of all of us is that higher troughs will resolve synovitis because of better control of bleeds and microbleeds. And we all hope that enhancing the trough levels will be the solution of, or will give us a step forward in the solution of joint bleeds and even joint inflammation. We do not believe whether the PEG has an impact, because we also have this FC fused protein and see similar effects of lowering down synovitis, and there's no PEG in. So we do not believe. Professor Kari, do we have another opinion? We do not believe that PEG has a pharmaco effect on the patients.
In my understanding, and I am sure that all of us know that PEG is an inert molecule, We've been using it for the last 3-4 decades in erythropoietin. Pegylated erythropoietin is one example that we use in hematology, and it's been very successful. I personally never heard of any complication along with PEG because I know that it does not react or cross-react with any other molecules in the body. Polyethylene glycol is used in transfusion medicine. Is a cloak. It's actually a cloak, a cloaking mechanism that covers the molecule, but I don't foresee that's going to create any problem. But still, it's worthwhile looking into.
Thank you. The joint score was very disturbing with regards to the progression of Prophylactic, where patients, despite having regular prophylaxis, they had progression of their joint score as time goes by. And as you said, this may be to microbleeds or progressive destruction of these. Is there any other similar look into degree of joint changes in normal healthy people? And I'm sure it will be definitely much worse in hemophiliacs, but the significant worsening is definitely likely to be more in hemophilia. But the natural deterioration of cartilage in normal healthy people.
No, it appears years earlier in hemophilia patients. We see joint destruction or joint pathologies in the mid-20s to 30s. So that's early for non-human beings. And it's very interesting to see that there's a big interpatient variation in hemophilic arthropathy. There are some patients that have only one major bleed and explain then hemophilic arthropathy very, very quickly in the surrounding of synovitis. And other patients bleed several times in the same joint, and clinically there's only very few arthropathy or pain in the patient. But when you very carefully look with X-ray or with MRI, you can see the changes. So the what the patient feels and what he tells you might be quite different to what you see in imaging. And therefore, we all believe that every single joint bleed is very deleterious over the long period of time, and we need to prevent it, every bleeding. And especially we need to prevent the buildup of synovitis. So, and there's a big effort now in Germany we have a guidelines for synovitis treatment. We need very high activities of factor 8 or factor 9 to treat synovitis very effectively, to get this rid of the joint and to help the joint to stay healthy over time.
Thank you.
May I just ask a question? I have a question to both of you, Prof. Hazan and Prof. Eckler. Having mentioned the arthropathy of the joints, many of our patients who have been ignored in the past time and they have some joint destruction, what do you think if we use glycosaminoglycan, which is something to improve the joint health? We use it in adults. This glycosamine is a very popular joint improving drug, but I don't see anything in the literature to encourage me using this in the synovitis. But I tried it on a couple of patients and they claim they see some success, but I don't have evidence.
It would be interesting to test it scientifically. I have no data about that. Although it's used in Germany, not only in the hemophilia community, right, but more in the eldering community. It's a big commercial effect, but I have no idea about real health effects on the joints. But science is open to investigate that.
I think in adult osteoarthritis, there are some randomized trials.
Of course, I mean in hemophilia.
No.
But in hemophilia, I'm not aware of any studies. Yeah. Maybe I can ask practical question, Prof. Eftar, and maybe Dr. Gary, if you have any comments also, please, on outside the clinical trials, how would you choose a clotting factor concentrate in this very warm, competitive, situation of, mashallah, very good number of products being approved and available, and also variation dosing regimen, variation in the way the studies were, somehow done, and absence of head-to-head comparison of the clinical endpoints. How would you select a clot factor concentrate?
That's a good question. So our procedure is the following. The patient is on a molecule, and this molecule is marketed as extended half-life. Then we offer the patient to change this same molecule, but for example, pegylated. He stays on his product, but it's only it's a more modern product. So the main issue is not for me to select the right product. The main issue is to convince the patient that a standard half-life product is not the best product for him. Because in Germany, we also compete now with sub-Q treatment with emicizumab, for example. And many patients want to get discussion with me or with my colleagues whether emicizumab is better than factor VIII. It's not the matter of having a long half-life factor VIII concentrate, but to move to sub-Q. So, but when the patient is open for further factor VIII treatment, this would be my procedure to let him on his molecule. When a patient is on a plasma-derived product, then we really have the chance to discuss with the patient whether he is someone who is reluctant regarding PEG. Then we have the Fc fusion protein, or is open for PEG. That we have also other products that single-strand products that extended half-life. So we have really then the option to choose with the patient what he means is the best. And this is also something that is joined with the treatment regime, once weekly or every 4 days. And so this will be discussed with the patient. But we have chances, we have options, and that's good. We have not only one product.
So, Prof. Gary, any input from your side?
Well, certainly. I mean, in our country, we don't have all the 10 or 12 factor VIII concentrate. We have some few of them. But we normally rely very much on the history of the clinical trials. You need robust clinical data convincing that you are picking up the right molecule. Of course, there are some minor differences between those factor concentrates, but I'm sure of one fact. Any particular factor concentrate that will pass the robust thresholds and things put by the EMEA and by the FDA and the local FDA in Saudi Arabia is going to be as good as the others. Whoever passed the exam is good for the practice. So I think it's good to look at the robust clinical history, clinical trial, and the approvals from the authorities. I think it's not difficult to choose because there are some similarities and there are some little differences it will be in the difference within in the range of minutes to hours if we talk about the long-acting factor VIII. And of course, there may be some difference in the prices. The price also plays a very good role in this.
I agree. Yeah. When I got the information prior to this meeting correctly, in Saudi Arabia, you have no plasma-derived products in your pipeline. You have only recombinant products. Is that correct?
No, I think we do have some still some plasma-derived. I had one patient today who was getting his treatment from outside our hospital. He was getting from Kidron factor IX plasma-derived. And in the Ministry of Health, mostly recombinant. The private hospitals and some university hospital, Prof. Gary can correct me if I'm wrong, they still have some plasma-derived products. Dr. Gary, Prof. Gary.
At least in our center, we don't have plasma-derived. We only have one product that we use as recombinant. So,
okay. So, one last question to Professor, from my side at least, but I don't see more questions from the audience. You in Germany, what fraction of patients are getting recombinant? What fraction of patients are getting extended half-life products? And I mean, recombinant standard half-life? And what percentage would have the plasma-derived products? This is just a rough estimate, if you may, if you know this information.
Okay, so the last numbers that I have in my mind is that most of the patients, the majority of patients, are still of standard half-life products, either plasma-derived or recombinant products. It's less than 30% of the patients injecting factor VIII that are on extended half-life products, but the number is rising. We had end of last year the change of the recommendations of German Society of Transfusion Medicine and Hemostasiology, and since then we have this 3 to 5% trough level in the recommendations, and this will make a push in the direction of extended half-life products. But we still have the majority on standard half-life products.
And of those on standard half-life, how many are plasma-derived? What fraction roughly?
I'm not sure, but it's not very few patients. It's a significant number of patients still on plasma-derived. This is clearly related to a very, very conservative feeling of the patients. When a patient uses a product and it works, he has ABR of 0. He does not want to change the winning team, for example. And when we tell him there are better products now for him for enhancing the draft, enhancing joint health, he tells me often, and what's about antibodies? I have a fear of inhibitors. And then we need to explain that that's not a reality. See, it does not have to have fear about inhibitors when changing the product. But it's really much discussion in Germany. It's easier if we would only have one product. So the situation is so, and the payers show us the numbers of rising euros needed for hemophilia treatment because of the extended half-life products. So it's but me as a treater, I'm extremely pro extended half-life products.
And I think there was some publications a few years back that I looked at into the seroconversion rates being almost nil for viral transmission, and I think this is from Germany. Is that right?
You mean with the?
I mean the seroconversion from being negative for hepatitis B or C or HIV to positive is almost nil. Is that right?
Yes, of course.
Yeah. Okay. I think if anyone of our eminent speakers will have to add any last statement before we close.
Only to say thank you to you, Dr. Kari. It was very interesting to meet you again. And
hopefully, yes, we'll meet together, all of us, soon.
Inshallah.
Thank you.
Very, very grateful to your elegant presentations, and I appreciate your help and clarity and very nice discussion. And again, I would like to thank the Saudi Society of Blood Disorders and the Novo Nordics for the support in having this meeting tonight. Thank you all very much, and have a good night. Assalamu alaikum.
Thank you. Have a very good night. Thank you.
Thank you.
Bye.
Prophet, I will see you. Muhammad, inshallah,